Hello and welcome. My name is Alana Gordon. I am a reporter and producer at The World, covering global health. This is a Facebook Live Q&A about the coronavirus pandemic, health inequities, and vulnerable communities. With me is Dr. Mary Bassett, director of the FXB Center for Health and Human Rights at Harvard University, and former commissioner of health for New York City. Thank you for joining us today.
Thank you for having me.
And you can post your questions for Mary and me on Facebook at Forum HSPH and at PRI The World, or you can email them to the forum at hsph.harvard.edu. And this Q&A is jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and The World from PRX and WGBH. We are doing this on Zoom through Facebook, so thank you for all your patience. And now I'd like to begin this conversation. Mary, the pandemic, it appears to be impacting vulnerable communities and groups especially hard. And these are people who are already facing difficult health, economic, and societal changes before this crisis. And so I wonder if we could start with your kind of observations on what is happening right now within these communities.
Thanks very much for that question. I'm going to speak mainly from the perspective of the United States, which is where I've seen most of the data. Now, as you point out, ever since the US began collecting vital statistics, the population of African descent has been sicker and died younger than their white counterparts. Evelyn Hammonds, who's in history of science on the Harvard faculty, points out that there's never been a single year when that has not been true in the history of US vital statistics collection. And the common diseases occur more frequently among Black and Latino populations. By this I mean obesity, diabetes, heart disease, occur at younger ages. And already we're carrying a higher burden. And now we think of these as the comorbidities for this new disease, COVID-19. So when this virus arrived, it encountered real differences in the population in terms of the risk of serious disease. But part of the story is also the risk of exposure to this virus. And that's the conversation that I think hasn't happened enough.
And what do you mean by that in terms of some communities and based on race and economic status being more prone to actually being exposed to the virus?
Yes, that's what I mean. And it's first thing to say is that this is not a genetic proclivity. This is not related to any biological difference between people who are classified in our country as either Black or Latino. This is social in origin. And what I'm referring to is the longstanding functions of race in the labor market and the housing market, in educational access and attainment. And all of these, what some people refer to as the social determinants of health, Black and Latino populations, Native American populations are disadvantaged. So when you have a virus that is acquired through the air, that people get when they have to continue working public-facing jobs as essential workers, it's estimated about 40% of our workforce is still going to work, and many of these are low-wage workers and disproportionately people of color. So you have a job which you take public transport to, maybe for quite a long time, and you may interact with the public as a driver, as somebody stocking the supermarket shelves, as a cashier. And then you go home to a crowded apartment that may be multi-generational. And all of those are set up for inability to follow the recommendations that you keep 6 feet away from people.
So I wonder, as somebody that is very well versed in the history and context of this, but also you mentioned data and looking at data in the United States, I wonder if you could talk about the role of data in health affairs. You recently wrote that there are glaring gaps. My colleague Rupa Shenoy reported recently about gaps globally in racial data for example, in places like Brazil. And you argue that there's this kind of mashup of reporting that can mask these health equity issues. So I wonder if you could talk about that, because we are observing things. We are observing problems and differences and inequities. Right. Where does the data play into
Well, I think often people, at least people not in public health, think that data are mainly for research purposes. But in public health, they play a much broader function than that. They enable us to identify issues so that we can take action to address them. So as everyone is aware, the federal government, through the Centers of Disease Control, until very recently wasn't providing race-specific data at all. So we simply were not able to determine whether or not there were these racial disparities emerging in both COVID cases and in deaths. More recently, they have started posting those data, but the data remain woefully incomplete, with under half of the reported cases having race data available. So this is not good. But most of the information that we've had on deaths have come from state and local jurisdictions, from cities. And there too, the data are incomplete. Massachusetts, I think, only had race-specific information on about a third of their reported cases. So what that means is that we have incomplete data, and we're not sure how closely it aligns with reality. Unless we think, though, that you're less likely to have your race completed on a form if you're Black or Latino than if you're white. If this is just across the board failure to record this information, then we have to take it at face value, even though it's incomplete. And certainly all of the data is in alignment with a 2 to 3-fold increased risk of death among people who are classified as Black or Latino across the United States. That means we need to take action, because there's no biological reason that should be happening that's innate to us. We have to take action. And the first step is to prevent people from getting infected. It certainly is true if you have diabetes or if you're obese, which has emerged as an important risk factor for a bad outcome. We can't fix that next week, but we can do something about worker protections and about recognizing that essential workers should be treated as frontline workers. We can do something about the risk of exposure.
I'm really curious about these actions, when you're talking about preventing exposure and having worked at the city level, and especially, are there examples of things that you're seeing or I wonder if you could talk a little more about these actions.
Do I know that these things are happening? Well, I think that
or that there are good examples that you're really pushing for.
Well, there's now a national recommendation that everybody wear face masks. So if people are going to be told to wear face masks, they should be provided to them if their job places them at risk. There should be every effort to reduce the sort of density of people working in assembly line type conditions, so that people can remain 6 feet apart. People should be given gloves. I know these are anecdotes, not necessarily reflecting broad policies, but in some settings, people who work these kind of jobs, particularly health workers, but it really should be extended, are offered alternative accommodation. I think what the stories that I've heard that are most wrenching are about people taking seriously their responsibility to continue playing these essential roles, but living in terror that they'll bring COVID-19 home to their families. And in some places, Cambridge, for example, and I've heard that similar things are happening in the Boston area, dormitories, which are now largely empty of students, and hotels have been made available to people as alternative places to stay. And that should be also part of what it means to recognize the importance of these essential workers and the role that they're playing in making life possible for all of us who get to stay safely in our homes.
I'm really curious, just bringing that back, and we are getting several questions in, so I want to get to those too.
Sure.
Some of this speaks to it. But when in connecting some of these actions with this notion of data, can you kind of clarify and explain again, like, why is it so critical to fill in these data gaps? What is lost in translating that to the actions and policies, or what you're trying to know more of when there's a delay, for example, in this collecting of things like racial data when it comes to something like coronavirus?
Well, everybody knows that we have very complete information on the spread of this novel coronavirus, period, in our population. So incomplete data makes us uneasy that we're going forward with a full array of facts at our disposal. And when we have missing data on over half of the people, that's not very good, and it should be fixed. But at the same time, at the same time, we have to use what we have. And I think that the point that I'm trying to make here is when all of it aligns, we have to come up with a reason to think it's not true. The mortality data are tracking with the hospital admissions data, not just in one place, but in almost every place. And the magnitude of the disparity and the speed with which it appears would suggest to me that it's structural in origin and not related to a simple failure to adopt public health strategies like hand washing. It has to do with with all these things I'm talking about. I think we have enough information to take action, but especially because people's lives are at risk. But the importance of data, I can't overestimate. I used to say as health commissioner to the senior team that I would cut programs before I would cut our surveillance capacity, because we have to know what's going on. That's how we measure where we are, how well we're going towards our goals, and whether our interventions are achieving what we want them to achieve. So data, surveillance data are really important.
So I want to get to some questions, which these themes speak to. This one comes from Reed Wilson from The Hill. He wants to know if you can address the growing outbreaks among Native American tribes, and specifically like the Navajo Nation, and what sort of unique challenges tribal governments face in taking on coronavirus.
Well, there are a couple of things going on here. One is the conditions of Native Americans, I think, because they now represent having been reduced by 90% after their contact with the colonizers. Such a small section of our population. We haven't noted, at least I as a public health person hadn't realized, that mortality rates have been rising for Native American Indians for years now. So there was the same background that I've ascribed to people of Black and Latino categories of high rates of preventable diseases in the Native American population. Then we have the conditions of life. I mentioned hand washing. Something like 30% of households may not have running water. So how do you follow that advice to wash your hands frequently if you have no running water? And then there is the perennially under-resourced Indian Health Service. So all of these combine to create really unacceptable risks in groups like the Navajo Nation.
Is the kind of health infrastructure or support across the board similar in communities there?
No, I don't think so. I mean, this is not something that I'm particularly expert in, but my understanding is that the Indian Health Service is really among the publicly funded health services in the country, one of the least well-resourced. And that's the service that you get to go to. We haven't talked about the fact that that when people get sick, they have to be able to seek health services, and we have many problems with that in our country, with many millions of people having no health insurance, and of course, if you have an under-resourced service, which is the only thing near you, then that is a problem.
This is a question that speaks to this question about food disparities, and it's from Betsy from Andrews from Eating Well. Can you talk about what sort of nutritional or hunger dimensions play into these sort of health inequities? And I also, this is just kind of like a nerdy thing, but I often see inequities and disparities kind of like interspersed language-wise, and I wonder if there's a nuance or difference.
Try and explain.
Yeah.
Well, I think both of them are rooted in the idea that these are unnecessary and unfair differences in populations. And the word either one of them is fine with me. The word that doesn't adequately capture that is inequalities. Because in order to address these gaps, we have to do more for the communities that have borne the brunt of bad policies over history. So there was a question about food, and I guess that this is speaking to the risk of obesity and diabetes, which are food related, as well as the outcomes of high blood pressure. And we know that a lot of a large share of the non-communicable diseases are driven by unhealthy food. And for communities of color in many urban areas, the availability of healthy food is a serious problem because many of these communities constitute what are known as food deserts. The only place that people can buy food are fast food outlets, either run by chains or mom and pop type fast foods, or corner stores where fruits and vegetables typically aren't stocked. So there's a difficulty not only in people being able to afford food that we would consider healthy, it's simply not available. And all these have a role in the avalanche of obesity that precedes the COVID pandemic and has placed us at risk and is driving the high rates of diabetes in our population. So that there are different access by race to healthy diets.
Mm-hmm. So it's almost like the situation now is just kind of making more visible in some ways the inequities that exist.
Yeah, I mean, I think that this pandemic is showing to us in the United States how rickety our public health system had become and how high the cost has been of allowing market forces to drive everything and not protecting people's ability to live a healthy life. I, with a colleague at the FXB Center, wrote a piece that was published in early March on noting that the US had particular vulnerabilities that made it possible that it would have the worst COVID-19 outbreak of all wealthy nations. And these included the high rates of non-communicable diseases, what we now call comorbidities, the real problems in access to health care because of under and uninsurance, and the lack of worker protections, including paid leave, including paid sick leave. All of these really, it's like a spark on a dry plain. And we had, I believe, the first death at the end of February. It's hard to believe that it hasn't even been 2 months and we're now up to 56,000 deaths.
Yeah. This question comes from Beverly. I'm going to abbreviate some of it, but it's about leadership. And then, so when you think about actions and when you think about government actions, how does leadership play into this, and at what levels is it important, or can the most impact be done to address some of these challenges now?
What we're seeing now really is most of the leadership in responding to the COVID pandemic in the United States coming from state and local jurisdictions. And it has long been the role of states to have authority in public health. It's an open question whether there should be more national authority, but at the moment the authority resides in the states, and that's where we've seen the leadership. Leadership is incredibly important, but I think also that people who work in public health shouldn't be afraid to talk about interventions that are outside of the health sector. I think when we say to ourselves that we can't talk about issues that we can't change, I can't change the labor market, I can't change, people's access to affordable housing, but I can still, as a physician and as somebody who's worked in public health, talk about the public health consequences of failing to address these issues. We're witnessing them right now.
Yeah. So this question comes from Mikal. Can you address the issues surrounding child neglect and abuse? I guess this speaks to some of the already existing structures or factors, but reports are currently down. But we also know that cases and crises may rise. But now kids are out of school, they're not playing with neighbors, it's more difficult to make contact. So what are ways to get the actual data and address a problem like this?
I think a lot of people are worrying what the stay-at-home advice means for families, means for women who are in abusive relationships who now sit home with their abuser all day long, and what it means for parents who, may be struggling with figuring out how to survive with children underfoot all the time. And there's been a lot of interest in seeking to document this. Really, at the moment, the main way is for people to call various hotlines. I don't have the numbers to give you, to ask for help. I keep thinking about the kind of army of contact tracers who we expect will be deployed, and how great it would be if we could envision them as playing a broader public health function, including trying to assess whether households they visit are people who need more support in coping with children or getting away from an abusive partner.
This question is from online, and when you were talking about this, I started thinking about models that exist in the United States, but also elsewhere, like community health workers.
Right, exactly. I lived for many years in Southern Africa, where community health workers played a very pivotal role in sort of bringing the community in touch with healthcare services. Yes.
And so transitioning, this question comes from online. And what stands out for you when you compare the United States experience with coronavirus with what's happened in countries with stronger social safety nets? So are there specific policy recommendations you would make based on that?
So
a little bit more broadly.
Yes.
More broadly.
For one, if we ever needed any more evidence that it doesn't work very well to have your health insurance tied to your job, with estimates of people with job loss now exceeding 26 million, and the numbers of uninsured expected to rise by 13.5 million on top of the 28 million people who are already uninsured. This would be a great time to have the conversation about how to ensure that people don't confront a pandemic fearful of their ability to pay for their illness. And of course, there are many other examples. Europe has been hard hit, but we have seen, not the kind of devastation in some countries that we're experiencing here in the United States. I always find myself getting pretty gloomy because the numbers are shocking. But it's also, before we wrap up, I want to make sure to point out that most people who get sick from COVID-19 will recover from it. And the fact is that 1% of a big number is a big number, but we expect most people to recover. So the ability of a country to be resilient and faced with a pandemic does relate to its levels of social solidarity and its levels of a social safety net.
So the conversations and recommendations, one is to start looking at how people can, who are losing health insurance now, is opening up this whole conversation, or you would like to see it open up this conversation?
I would like to see a conversation about having a national health insurance scheme. one that people have, like you can expect to have a fire department respond to a fire in your house, that you would simply have by virtue of your residence in this country.
This question is from Kathy, which is, what are the challenges with coronavirus or COVID-19 as it interacts with other epidemics? I mean, you talked about things like diabetes and obesity, but what about something like the opioid crisis and how that intersects with vulnerable communities?
I was just looking at some data from New York City where they're estimating that there have been 15,000 deaths, which is a big chunk of the US number, because they're including not only the diagnosed COVID deaths, but also the ones that are probable. And then they still have a higher number of deaths above that. We're all wondering, where are the overdoses, the strokes, the heart attacks, because people are staying away from hospitals, fearful that these are places of contagion. I think that we're going to uncover that the cost of this pandemic has not just been in direct COVID deaths, but in the inability to respond to these other epidemics that the person who asked that question noted. But the causal basis, of course, is different. But all of them arguably may relate to the kind of fissures that have emerged in our society that make it really difficult for people to lead a decent life and maintain their health.
Mm-hmm. And again, we are live with Dr. Mary Bassett taking your questions. You can post them on Facebook, although we do just have a few minutes left. This question comes from Anna. Would you be able to comment on, we've been hearing a lot about immigrants detained in the US, and the conditions are not conducive to preventive measures that are being asked of the general public. Mm-hmm. Is this a violation of human rights? And I'm also curious, or I want to add something on to that, detention centers, but also you've been part of a group that's calling on the governor here of Massachusetts to address the jail or prison population here, because those conditions can make the spread of coronavirus much more pronounced.
Right. All congregate settings are settings in which people are at risk. We've seen it most markedly in nursing homes, but jails and prisons, detention centers are all places where people, where the idea that you keep 6 feet away from people is just not practical. People live in crowded spaces, eat in crowded spaces, and even the recommendations on hand washing may not be very practical. So all of these are examples of ways in which people are arguably being sentenced to death or the possibility of death, when the violations that brought them there would never have carried such a risk. So I would advocate on public health grounds that all of these places should rapidly reduce the number of people held there. Anyone who's not a risk to public safety, and many immigrants are not. We have, something like 10 million undocumented immigrants in the United States, maybe 16 million households which are mixed status. And they're paying their taxes, law-abiding people, and they should not be held in detention if they pose no risk to public safety, because their health can't be protected. You can't stop the air, and that's how this virus spreads.
Have you seen any communities or places do just that?
Well, Iran did it. I mean, they let out 70,000 prisoners, and that's not exactly a democratic setup. It was, I think, nearly a third of their incarcerated population, and they released people. In the United States, modest numbers of people have been released on humanitarian grounds, and I think that there's a good case to continue to be made that in this case, public health really should trump the desire for punishment, and nobody who's not a risk to public safety should be incarcerated at this time.
We're just about out of time with this Facebook Live, but I wanted to just give you a chance to kind of offer some final comments about when we think about racial inequities and we think about what this pandemic is bringing to light, but also some of the challenges. I wanted to just give you a chance or see if you'd be able to give some like summarize or the points that you're thinking about right now in terms of like what, given all that's come to the surface, like what are the things that need to be happening right now in your mind to be addressing this?
Thanks for that question, Alana. And these fissures in our society are historical and contemporary in origin, and they are indeed being revealed by this epidemic, this pandemic. And that's what epidemics do. They reveal the fissures in our society, and this one is no different. All of the variation in both the acquisition of COVID infection and the likelihood of not having a good outcome from it, I would argue are largely social in origin. And in that sense, we should consider that it can be changed. But some of these things can be changed more rapidly than others. And a focus on the role of essential workers, many of whom are low-wage, precarious workers, and the risks that they play, ensuring that we do everything as a society we can to reduce the risk of exposure so that the people who are stocking the shelves in our supermarkets and at the checkout counter and delivering all of those boxes that people are ordering, and the postal workers who are walking up and down the street keeping the mail going. All of these are workers that deserve protections, much as we think of people in healthcare facilities. These are things that could be done. They could be done now. And it includes a whole host of measures, but at the least, no one should be looking around for a face mask, for gloves, or for the ability to be tested.
Well, Mary, thank you so much for fielding all of these questions today, for joining us.
Thank you, Alana. It was a pleasure.
So that concludes our Facebook discussion, and this Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and the World from PRX and WGBH. You can view this full discussion on our Facebook pages and send feedback at Forum HSPH and at PRI The World. And you can join us again next week, Tuesday, May 5th at noon Eastern Time, when we will be talking with Dr. Karen Karistan Conan about the mental health consequences of this pandemic. So important topic like this one, and let's keep the conversation going.